Thank you very much. Recording in progress. Very good. Okay. Thank you very much. And so this is two workshops, one for HER2 immunohistochemistry, and then following that, the HER2D dish. It's the same workshop that we did 6 months ago. So if you already seen this workshop, maybe you don't want to stay. There are one or two kind of new things, but not very many. So apologies for those of you who already seen this. I would like to put a pointer, but I failed miserably. I think it's this.
That's
you think this one?
navigating. It should have been.
Pointer options, visible. Okay.
That doesn't.
Anyway, okay, so we're going to go through the current categories of HER2 staining, diagnostic categories, and then we have a very practical approach. And at the end, hopefully in the last 20 minutes or so, we have a lot of case studies, and it's a bit interactive, so we do some polling and to see what you think about the diagnosis. Apologies if there will be noises because we are in the lab, so there will be blipping every now and again, disclosures. Okay, so I think this is the kind of slide really that we ought to talk about, because we have seen this transformation of HER2 diagnosis in breast immunohistochemistry. So for 20 odd years, it was very, very, very simple. There was an HER2 negative or HER2 positive decision making, and this was done using immunohistochemical scores, 0 plus, 1 plus, 2 plus, 3 plus. And if we weren't very sure that whether it was positive or negative, we would have a second test, which would be in situ hybridization. This system, despite scaremongering from some of our colleagues, work very well, and the concordance amongst pathology is really, really high. The amount of errors made is a few percentages, and we are well into the 90s, 95+% concordance. It's a very robust system.
Yeah, we need to mention that we're talking about breast here. So
only breast, gastric is another matter. Fantastic. Yeah, of course. Now, then a few years ago, the HER2 and DB04 reporting meant that we created a new category, and this new category was HER2 low. So still using the 4 immunohistochemical scores, but now the actions were different. We still had a HER2 positive. We still have a HER2 negative, but some of it was also called HER2 low. And again, still the HER2 in situ hybridization to decide. Now, realistically, this system hasn't been very robust. And hasn't been robust because some people started to analyze diagnoses made 10 years before, where we weren't aware of these differences. And they said, oh, we're all over the place between 0 plus and 1 plus. But that was unrealistic. But when we then test the pathologist population to try and distinguish better 1 plus to 0, we realized that we are not very good. And so the concordance rate for some of these cases, we were still very good at identifying the HER2 positive. We were still very good at identifying the HER2 negative. But when we wanted HER2 low, we had the concordance rate went down to about 60% in some studies, a little bit below in other studies. So clearly there was a problem. And my approach to this has always been, the problem is there because we don't tell each other exactly what the rules are to diagnose these categories. And so we started to do a little bit of work in tidying up these diagnostic categories so that, and some of you have already been in some of our workshop where everything is quite schematic. There is an interpretation algorithm. And if you do follow the interpretation algorithm, the concordance rate comes up a lot. However, unfortunately, let's see if I can get the next slide. Oops, there you are. Unfortunately, DB06 reported. And DB06 established a 4th diagnostic category, which is HER2 ultra low. So now we need to distinguish with reliability at 0 plus with some membrane staining. So that for you and me means anything with less than with 10% or less staining from something that has no staining whatsoever. And the added complication is that this diagnostic category you see here, and these ones you see here, are dependent on the HER2 status. So the manufacturers of the drugs that are supposed to be used with this started to use these categories dependent on the HER2 status. Now, this, to my mind, created a lot of confusion. And we said at the beginning, the pathologists need diagnostic categories, and we can name them. And then the action of whether you are eligible for a drug or not, it depends on the HER2 status, but that's another matter. But at least pathologists understand how to diagnose the HER2 staining. And so unofficially, because the manufacturers of the drug are still a little bit reluctant to embrace this ultra-low category and so on, we kind of started to use this word null. Null in our word means I don't see any membrane staining whatsoever. No? So has replaced that nomenclature HER2 negative, because this HER2 negative was a nomenclature made when there was positive amplified and negative not amplified. And this is kind of superseded. In my mind, to tell you the truth, also this HER2 positive is not very good, but is been there for 25 years. We are not going to get it out of it. So to me, this should be HER2 overexpression or HER2 amplification, amplified.
Yeah.
And this is low, then it goes well, and then ultra low, it goes well, and then nothing. Okay.
Yeah, the nomenclature doesn't actually match. Like we have these categories, but then we're talking about different.
Some of this is historical,
elements.
so we need to live with it. But I think everybody understands what HER2 positive is the 3+ immunohistochemistry, which in the greatest majority of cases is linked with the amplification of the protein. And just for you to understand, because this HER2 positive category is the target of trastuzumab or panitumumab, so these monoclonal antibodies that target directly the HER2, they need a protein. So you may have a case which is amplified by ISH, but doesn't express the protein, very rare, doesn't express the protein, that's not going to respond. So you always need to see whether there is protein. That's most important, is the protein there. Fantastic. And the reason why not all cells that show positivity, so overexpression, they don't have behind the amplification will respond, is because the amplification is a testimony that this mutation is oncogenic, is driving this cancer. So you could overexpress without this protein being very important for your survival. And therefore, blocking it will not cause an effect on the tumor growth. Okay, having said all that, oops, we advance. A few slides to understand what it is that we are looking on the slides. And there is a difference between the clinical IHC test for HER2 and this concept that there is HER2 on the protein, on the cells or not, because it's not the same. So it is kind of accepted that at the moment, for membrane staining, the limit of dissection, LOD, for immunohistochemistry is around 3,000 copies per cell. Around it. These are broad numbers. They're not going to be specific entirely. And so below 3,000, I'm not going to be able to detect usually using immunohistochemistry. Above 3,000, I start to see some immunoreaction on the membrane. These are for membrane staining only, okay? But our immunohistochemical test for HER2 clinical is geared to be not show anything below 20,000 copy per cell. And this number is the number, rough number of the normal cell. Normal breast epithelium has HER2, but with our HER2 test, we say it doesn't stain, or it may stain very faintly or on and off, etc., etc. And just for you to have a proportion, amplification is in the million per cell copies, yeah? And then a kind of indeterminate, what we call 2+ are around this range, 500,000, 1 million, these kind of things. Okay, so if you stain properly, so use the immunohistochemistry to its full potential, you will demonstrate a little bit of membrane staining
In the normal.
in the normal. And then we know about the HER2 plus. Okay, this is fantastic. Okay, so we have the typical IHC test, which is very sensitive, and we have decreased. So a typical IHC center, you see, you demonstrate membrane staining in normal breast epithelium. You decrease the sensitivity, so you no longer stain the breast epithelium. That's a typical IHC negative. This is tumor, and this is negative. Yeah. So artificially, you decrease the sensitivity of this test, and that's fine because we want to detect overexpression.
Yeah, and in this realm of HER2 low, isn't that's an adequate?
That's a bit of a dangerous game, because now we are going to try and interpret tests that are at the limit of detection, where a little, some butterfly wing but fluttering will change the outcome. So that's very dangerous. Okay. So the warning is that there isn't one clinical IHC test. There are several. If you want to go FDA approval, there are, I think, 3 or 4. And each of them will be very good at the upper end of the, so they will always be quite satisfactory in detecting amplification, but not in detecting low level. And that's what you need to keep in mind when now you're asked to detect HER2 low and HER2 ultra low, that at the moment, the only clinical IHC test that was used in the trials was the DB04 antibody, and we can't escape that. So you need to understand the limitation of the test you provide if you don't provide DB04.
But this is interesting because this also relates a lot also to the intensity or the perceptible intensity of staining. But then now when we rely, because between positive or amplified, positive overexpressed or negative, usually when HER2 is overexpressed, is diffusely overexpressed, especially in breast cancer.
Yeah.
But now we rely a lot on proportion of tumor cell staining, and you wonder whether the pathway of testing should also be altered in a way of testing multiple samples.
So this is the limitation of continuing to use a test that was designed for something else, and adapt it to use it for this low-level expression. So really, the pathologist community has always said, wait a moment, for these penumbra cases, for difficult, small amount of staining, we need a different test. But of course, there is no appetite from the industry to start changing the regulatory framework and the approval framework for their drugs now that they have it. So it is here more or less to stay. But if we understand this, we may be able to provide better service, better clinical service. So is this test reliable? We said about it, we are very good when we have the 2-tier system, positive, negative, good things. And this is the interpretive algorithm that we adopted once the problem of interpreting, of identifying this low-level expression arose, so with the DB04 trial and HER2. And this is very much a practical algorithm. So you look at the guidelines, they don't tell you this, but then you speak with the pathologist and say, well, this is how we work. So this is practical, put on paper what we practically do. And this is the same approach they do in the States. They look at magnification, like staining intensity using magnification rule. And then they look at the amount of staining, distribution of staining, how many cells are put, and then they come up with an IHC score. In America, they do it the other way around. First, they look at how many cells stain, and then they say, what is the staining intensity? But that's beside the point. Okay, so it's a step-by-step approach. Now, the whole world use magnification rule, but for those of us that are new to this field, we'll go through the magnification rule. So please remember that these IHC scores, 0, 1 plus, 2 plus, and 3 plus, and now 0 without membrane staining, 0 with membrane staining, so 5 classes, 5 IHC scores, they are just IHC score, they're not a diagnosis. The IHC score plus the whatever regulatory approval there is around them will give you a diagnostic category. So the 0, the null, ultra low, et cetera, is the result of the approval of the regulatory approval. So don't confuse 1+ staining intensity with IHC 1+. IHC 1+ is not just staining intensity, it's how many cells stain.
Yeah.
So it's not just staining.
So this is the score. So it's the sum of the three parameters that we use.
Okay, so we spoke about this. In the low category, we are not concordant, but I feel confident that if we define well these categories, we will be concordant because we're not idiots. If you tell me how to score things and how to interpret
So what do you think the biggest problem is?
So at the moment,
proportion, understanding of the
no proportion.
patterns.
So proportion will be really difficult in some cases because we have this cutoff point of 10% in many of these categories. And 10% sometimes is very obvious, is much less than 10%, much more than 10%, but sometimes is, I don't know, could be 10%, could be 11, could be 9. And obviously in a big section, there will be some imprecision, but the number of cases that are so difficult for percentages will be very low. I think the most challenging point now is in this ultra low category, because one cell staining in the whole section will say is ultra low, not null, and then go and find the one cell. This will be the difficulty. Okay. So as Adelina was saying, 3 parameters in staining intensity, distribution of staining, and number of cells staining will give us an IHC score. And it's kind of a cascade, yeah. So the distribution of staining, it's very important to understand. It is complete staining, membrane staining versus incomplete membrane staining. We'll go into it a little bit more in details. The cutoff point in many of these things is 10%. And the staining intensity, we use magnification rule. Okay. Staining intensity. This is our friend Joseph Rushoff, who didn't think about magnification rule because people were using magnification rule, but he was the first one to say, guys, just let's keep our heads together. Let's use this throughout. And then he did a little bit of work around it to show how easy it was to apply it and how concordant we are in applying these things. And then he devised a little bit of an understanding on why this magnification rule works. Originally, this magnification rule was to use a low power, and if you see membrane staining at low power, this is strong staining intensity, an intermediate power, which was 20 or 10, and that defined moderate staining intensity, and a high power, 40, that decide weak staining intensity. For a lot of reasons that also are to do with our understanding of membrane staining in PDL1, we've kind of decided that time 40 is a dangerous lens to use now, more or less. So be careful about time 40. You also need to understand, and we will show you why, these numbers, times 20, times 40, times 5, are dependent on the quality of your lenses that you use. So they're not universally the magnification. In fact, it's called magnification rule, but it's not magnification. It is instead quality of the lens. Okay.
Yeah.
But nevertheless, and also the other thing that you need to keep in mind that despite the fact that we keep the distinction between strong, moderate, and weak, actually is either strong or everything else. That we could really go into 2 staining intensities, strong and everything else. Nevertheless, traditionally we have 3 staining intensity. We'll keep it for a while. Okay, and the basis of magnification rule, which will not go into it, is the fact that each lens has a different power of resolving 2 points that are close together.
So that's, resolution.
Resolution.
Basically.
And resolution, not magnification, but resolution. So basically, the optical system are such that the moment two points are too close together, you don't see 2 points, you see a blur, So there you see blurring, not sharp membrane staining. Here you see sharp membrane staining. And this separation depends on the quality of the lens you use and the times for, I think we have a little
It's
something.
also the magnification as well.
So this is magnification, but you see as the magnification changes, the numerical aperture changes and becomes bigger. And this is the resolution of 2 points. And it almost double for many lenses until it flattens. So there is very little difference for time 40 and time 60. Yeah.
And
so
I think people notice that when you go for even at times 40 sometimes, but when you go to times 60, it's much more fuzzy, the image.
Yeah. So magnification rule also depends on the quality. These are plan achromat lenses, plan apochromat, and this is plan achromat, obviously less resolving power. So it depends on your microscope as well. But this gives you a gradation of staining intensity. Okay. And the reason why we stopped relying heavily on time 40 is because we realized that our brain translates the images, translate the input. So the eye gives the input, but the brain modifies it in many ways. And so I just want to show you this checkerboard illusion to make you aware that our brain fools us. So it's a famous illusion. There is a checkerboard and there is an object casting a shadow. And you can see that square A is the dark square and square B is the light square. So what I've done is I've taken 2 discs and copied the staining intensity of A. So these are exactly the same. If I put 1 disc on A, it will be the same. You will see. Yeah. If I put this other disc on B, you will see B is dark. But my brain say it doesn't work. It cannot be dark. I'll make it white. Yeah. And this is why sometimes we see things that we swear, no, this is membrane staining. It's very faint, membrane staining. But then when we ask a machine, like an image analysis, to say, is there membrane staining? They say, there's no membrane staining here. It's gray. It's not real dab. Okay. So, and these happen at very high magnifications, and therefore be careful. I don't say don't use it, but be wary that you may be fooled, and therefore, I mean, usually you will see staining at times 20. Yeah, then maybe you put time 40 to say, okay, I can see better, but you will see at times 20. If it only appears time 40, think very carefully. Okay. Second parameter is distribution of staining, and originally was complete versus incomplete, or continuous circumferential versus discontinuous non-circumferential. But we then learned that there was, so this is very easy. This is continuous. This has got gaps. Yeah, we can recognize that. But
if
then
they're large enough.
Yeah, they're large enough. Yeah. But then we learned that there are some cells that do not make photoreceptors on the luminal aspect of the membrane. Yeah. So we also think that these U-shape staining pattern are also complete, providing they are complete on the other side. So U-shape is complete.
So cells have compartments. And then this is a micropapillary carcinoma, but we also rarely in carcinomas with tubular morphology that are cytologically
with
higher grade.
Yeah.
We do see basolateral
stain
similar to this.
So the circumferential or basolateral, also just basolateral staining is in the context of the morphology. If you find something that should not have basolateral staining as basolateral staining, you say, well, I'm not really satisfied that this is complete staining. Cool. And the something new that is not that new, but because we've been talking about it for a year now, is that there is another parameter in this distribution of staining. Is the gap is something you need to keep in mind. If there is an interruption, even if it's a small interruption, that's not complete. Let's be clear. Okay, it's not complete. But also let's keep these things. And also I'm going to skip these slides because they're not very important, but the problem is that some staining is uniform and some staining has variable thickness. So be wary of variable thickness, because we have seen cases where there is uniform membrane staining, although weak, And then we say, well, this is very suspicious. Why is it so uniform? We do the addition, it's super amplified. And to me, these could be cases where the immunohistochemistry sensitivity has dropped for some reasons. We didn't fix well, we didn't process well. Life is what it is. But the uniformity of staining gave us a warning, because it's difficult to achieve uniformity of staining if there aren't so many molecules on the membrane. So so now we have another thing to look at, which is it of variable thickness? Because if it's of variable thickness, it's very likely not to be the HER2 positive staining we know. So examples of this discontinuous, but also variable intensity. You see, thick and thin. Thick and thin, not right. This is 1+ staining intensity. Yeah?
Yeah.
More thick and thin.
Yeah. Sometimes we see it fading. Some other times, like here, you have these sort of dabs of stronger.
Yeah.
Uniformly, it can be uniformly, let's say, moderate or even moderate to strong intensity, but then they have these little gaps between.
So at best, when you see of strong staining intensity and it's discontinuous, at best, this is a 2+ staining pattern, but not clearly an outright 3+.
Yeah. That's what we need to get straight.
So again, you see here, you have this emphasis at the junctions of the cells, and then it fizzles out, it becomes thinner. This is not a 3+ continuous staining. This is a discontinuous staining, and we need to learn this staining. Okay, we'll skip this. Is about staining. We want to think about understanding staining patterns. What are staining patterns that at the moment we think are non-specific and therefore are non-scorable? Okay, let me tell you that behind some of these staining patterns that we call them non-specific, there is very little science, but nevertheless, this is the convention. We are just applying convention. So when you have staining, quite nice and strong, but you see it's a little bit fuzzy and is almost in the lumen of these tubules, it's kind of probably extracellular. Yeah.
Yeah, this is kind of the reverse of the basolateral. So you only see in the lumen. It can be more, this looks inside the lumen, but it can be also, you can see it right at the apical surface.
20 years ago, when we were scoring this thing, we would say 1+. Well, because there was no, it's negative, and 1+ negative was the same. There is no consequence to it. But now that 1+ means therapy, we now say, no, this is not.
And this is kind of an easy example because we have tubules, but you can have some sort of more cribriform masses, or the lumens can look more abortive in a way. So you need to be careful with that.
Yeah. Okay. Sorry, what did I do? Okay, this is higher power. You see, it's clearly probably outside, probably it's in the mucus or in the glycocalyx of the cells. Who knows? Okay. And by the way, here you will see that every now and again you will have a sense. Oops, I went too far. You will have a sense that there are one more above. Yeah, you will have a sense that perhaps there may be a little bit of membrane staining, but it's very iffy. This is very blurry. I wouldn't really accept. And this is a very high power picture. You see, there is a line here. I'm thinking, oh, maybe this is membrane staining. I don't know. Okay, so another staining pattern is this basement membrane, like Adelina was saying, that glycocalyx, and this is the opposite. This is at the base towards the extracellular matrix. Yeah, and again, this one, very happy. I would have called it 1+. But now I know this is not 1+. Again, sometimes it's thick and thin. But to me, the important thing is that in between the cells here inside, there is no line. I cannot see a line. Yeah. So I cannot really verify that this is membrane staining. So this is, I think, higher power.
Yeah.
Yeah.
But it also has a different quality. It's usually thicker, a bit fuzzier. Although
often it's fuzzy. Often you think it's very strange. It looks like membrane staining, but it's not very sharp. Yeah, and that's
and sometimes it actually gives you the impression that it's outside the cell.
This one could be membrane staining, much more delicate.
Unless it's a space or like a
space. But there may be some membrane staining because this is inside.
Yeah.
So basically, be wary of staining that is only on the outside of the cluster, and it's also a bit discontinuous. Doesn't go up around up the cells, etc. So this is basal membrane staining for no scientific reason. We say this is not a specific staining, but that's what it is. And then here is an example of something that kind of some of us would be tempted to say, but I know it's cytoplasmic, but look, I can see lines. And I think this is, you need to be careful because something has gone wrong here. I'm not sure what. Probably not very safe, because how do I know that this is not the gray line
between the cells?
Yeah, I don't think you should. Again,
it's difficult to see anything. Yeah.
Don't call this membrane staining if you can avoid it. And this is an example of weaker cytoplasmic staining. And again, you could start to argue, but I think I see lines. But be careful.
We're again a high magnification here, so.
Okay, so cytoplasmic staining, and then it can be focal. And here you see how this looks like a macrophage or we are staining the cytoplasm of a macrophage. There is something it's not right, but it is certainly not in the membrane. It's fuzzy. This may be membrane staining here.
That could be a combination.
But this would be the difference between an ultra low and a low.
Yeah.
For instance. Okay. And sometimes we see this very strong granular cytoplasm membrane staining together with cytoplasmic staining. And probably you could think of it as membrane staining. Obviously be careful with it. We're saying yes, but with caution. And this looks like strong staining intensity. And these are some of those cases that you say, I don't know what's going on. This is odd staining pattern. Let's do an ISH to make sure I'm not missing some amplification. And then probably we would call it low or ultra low, depending on how many of these cells are staining.
In this case, the important thing, you distinguish the membrane staining from the cytoplasmic. There is a contrast between the two.
And then this is another extreme case of granular cytoplasmic staining. But here, I'm not convinced we can really reliably say there is also membrane staining. So probably not. And this is an extreme example of something that has gone wrong, or maybe specific, who knows? But nuclear and cytoplasmic staining, it's not really usual.
We usually see this in other types of cancer, not in breast, but we do see it very rarely. I think I had 1 or 2 cases per year.
Sometime in apocrine tumors.
Not quite to this level.
No. So, okay. So, what are the staining patterns that we think are acceptable and we need to recognize? So, clearly this nice circumferential staining. This is a slide I love because obviously you all see this is DCIS, but you would have noticed that here there are a few cells coming out of the DCIS of invasive carcinoma. So it's kind of caught in the act of starting invasion. And these are clear chicken wire type of staining, very strong, at low power, very detectable. And we talked about basolateral. This looks more like moderate staining intensity than strong, but it would count as complete circumferential staining in our assessment. And here is another example of things missing at the top, and also have some disturbance from cytoplasmic staining. But I think most of us would be comfortable in saying that there is membrane staining here as well.
Yeah. Is it possible that some of this is because of the thick membrane staining or a lot of protein, because it looks like some of the nuclear
obviously, and if you think about it, when you look at the in situ hybridization, you see that there are like hundreds of genes sometimes in these cells, and then you don't know whether all of these genes produce full-length protein, full functional length protein. Some of them may be truncated, some of them may stay in the cytoplasm. We know very little about the life of the molecules produced by these amplified genes. So, and also, if you are producing such bucket loads of protein, some of them will stay in the cytoplasm because that's where they are made and they're assembled. So it's possible that you stay in the cytoplasm. Okay, and here again, complete circumferential membrane staining. Although there is cytoplasmic staining, I think many of us will be comfortable in calling this membrane staining. And here again, what we said before, this incomplete, this discontinuous membrane staining. Set your eyes to discontinuity and you will not make mistakes. To me, more than being analytical and say how many cells, etc., the staining pattern is 1+.
Yeah.
And pathology should be much more happy and much more familiar to look at it overall and say, this is the staining pattern of 1+.
Yeah, I think the take-home message is there's a lot of value in the staining pattern. Of course, we need to pay attention, be very careful, because once we start having, let's say, strong intensity staining, then we need to make sure that there are no major artifacts, and then because we might need to do ISH, even if it's discontinuous.
More higher power of beads on string, this discontinuous, this variable intensity, variable thickness pattern, and more example of these things. So the moment you see this and learn it, these are the typical clustering around the 3 or 4 junction of 3 or 4 cells and forming these crow fits. And there's more example of this. Okay, and then again, some basolateral staining, but discontinuous, so not continuous. Okay, so there are some cases that we now need to pay more attention where there is weak membrane staining. So the message is that while before it wasn't that important, we could dismiss it. Now a small amount of staining is important to find the ultra low. Now, importantly, ultra low doesn't mean very weak staining. Ultra low only means there is staining in less than 10% or 10% or less of the cells. So it's the amount of cell staining, not how strong the staining is. More examples. So, okay, so we got the message that there are these staining patterns we need to appreciate. Here you see is at the junction of 2 or 3 cells. Okay, fantastic. Now I would like to show you, okay, so this is our algorithm for interpretation. So first of all, determine the staining intensity. If you see at low power staining, strong membrane staining, that means it's strong membrane staining, 3+ in our pathologist world, you know, not IHC 3+, but 3+ in strong staining. And then you go and think, is it complete? Is it incomplete? If it's complete, apply the 10% rule. More than 10%, 3+ means IHC positive, HER2 positive. If it's incomplete, if it's less than 10%, you need to do ISH. You call it 2+, you grant ISH. Now, this is something that the guidelines don't tell you. What you do if you see incomplete membrane staining that is strong, regardless on how many cells you see it. And ASCO-CAP say it doesn't exist. All of us say, no, I've seen them, a few cases. So these are cases where you need to reflex to ISH. Ask in situ hybridization, is there amplification? Is there an amplification?
But let's say if you have a case that you have a core biopsy and you have only 2 or 3 cells, a few cells that are strong in a background of weak to
complete or incomplete?
Moderate, incomplete.
I think
or complete if you
or complete. So if it's complete, either case, this is odd. Let's ask ISH, because when we have a core biopsy, the most important thing is the patient potentially eligible to have a very good response with trastuzumab plus chemotherapy? Can't miss that. You know, we need to do the work. And if we can show that there is amplification, then the oncologist can take a decision on whether to treat in neoadjuvant settings. If instead is incomplete, then or in any case, if the staining is in less than 10%, so you cannot call it HER2 3+, you probably want to repeat on the excision, because it could be that there is a lot more positive tumor cells, and then your core biopsy is a small sampling, is not representative. So, okay, but in any case, incomplete, you should be strong, incomplete, you should reflex. Bear in mind that although we say, can you see at time 4, time 5, this is strong, There will also be cells that express weak or moderate staining. Usually there is a spectrum of staining intensity. Okay, if I don't see anything at 4 or 5 times, put times 10, and if I see something that defines the moderate staining intensity, and then at this point, you are no longer accessible. This is no longer accessible. HER2 positive is no longer possible except
through
ISH. Yeah. So visible times 10, yes. Is it complete? Yes. Is it more than 10%? Fantastic. ISH. That's 2 plus. ISH. ISH will tell us. Is it less than 10%? I can't go. Well, you can do ISH if you want to, but that's not in the algorithm. You need to call it 1 plus if it's complete. If it's incomplete, you don't have access to ISH. ISH at moderate staining intensity is only accessible if it's complete, not incomplete. And then you apply the 10% rule and you call it 1 plus or 0 plus. And then now we have this 0 with membrane staining, which might be, might be here.
Yeah.
Yep. Okay. So if you don't see staining at times 10, you put times 20, and that defines weak staining intensity. But the algorithm is exactly the same. And let's be clear, if you see only staining at times 20, which is complete, and is in more than 10% of the cells, please do an ISH.
And it comes down to the staining pattern again, that we need to take into consideration in the context of the scoring algorithm.
Okay. Okay, so the new scoring algorithm obviously has this, instead of having HER2 0, has this ultra low and then null. Okay, these are the words that we need to keep in mind. Okay, so they are here. Yes, that's the same score, the algorithm with the thing. Okay, so warning. One warning that we spoke about the other time. There are a lot of people that say, for some reason, for a lot of good reasons, clinically, histologically, I feel I'm not comfortable to call this 1 plus negative. I want to ISH. Okay, that's fine. Reflex to ISH. But don't call it 2 plus, because I see 2 plus is a score. Say it's suboptimal. I'm not very sure. I want to do another test. Call it indeterminate. Why? Because then some clever clog will do statistics on you, and you'll say, oh, you have a very high number of HER2 2 pluses. You didn't do 2 plus. You say that something is wrong here. I want to do more.
Plus, now with the decalcify, for instance, specimens where you want to do with the guidelines, like for instance, RCPAT tells us to reflex to ISH regardless. And if you have 0 expression and your IHC worked, you can't call it HER2 low.
You call it, and then somebody review and then say, oh, Adelina, why did you call it 2 plus? There is no staining here. What are you talking about? Okay, fantastic. Okay, so now we have some case studies, and Hannah will help us. How much time we have? 40 minutes. Hannah will help us by putting a poll, and if you could click on these 5 diagnostic categories. So null, 0 with membrane staining, that's ultra low, low, indeterminate, 2 plus or 3 plus. And we'll show you the picture. Let me see, case studies. So here it is. And for your convenience, these are pictures taking a different magnification. So you can apply the magnification rule, times 5, times 10, times 20, and times 40. And then you need to assess staining intensity with magnification rule, complete, circumferential, or incomplete, discontinuous, and then proportion. Okay, so this is case 1, and then very kindly Hannah will put a poll, and then remember that you need to click also on what do you need to do?
No, this is just because you're
I know. Okay, fantastic.
we're just seeing the score progression.
Very good.
Okay, interesting.
Keep voting, keep voting. We'll give you a few more seconds. Fantastic. Okay. And we can say, okay, we can share results. Okay, these are the results. So the greatest majority thought this was HER2 low, but there is a sizable amount that say this is indeterminate, HER2 2+ indeterminate. Okay, let's stop sharing. And then Adelina, oops, how do I get rid of it? Like this. Adelina, tell me what you think. Can we call these 2+? Would you call this 2+?
So I think the scores are the expected distribution. We need to use the magnification rule. So at ×5, that's when we decide, like you said, strong intensity versus all the other intensities.
Is there anything here?
This decided. For me,
for some reason I keep getting polls up. I'm closing them. Okay. Yeah. Is there any staining here?
I mean, there's definite staining. But now the question is, can we see membrane staining?
Exactly.
And to me, this is not very sharp.
No, very sharp. What we mean for can you see membrane staining is can you see it without straining yourself? Because I'm sure that if you probably strain yourself, maybe you see it.
I see some blobs of staining, if I'm honest.
No membrane staining. It's not, you need to be comfortable. Say like, look, this is clearly membrane staining. It's not. But then this is ×10. No, is this ×10?
I think they're both similar magnification on the diagonal.
I have no idea what this is.
So, but it looks pretty similar in any case. But then we see.
I think it is 10.
Yeah.
Yeah. Okay. So this is moderate staining intensity.
Definitely moderate.
Is it complete?
Definitely not.
There are gaps everywhere. Yeah.
Everywhere.
And remember, you need 10% complete to call it 2+. Okay.
So it's not the case.
Now, I know that there were a sizable number of participants that said, I call it this 2+. But in reality, 2+ will tell you it's not amplified. And then you can come to your diagnosis. So, okay, you wasted a little bit of time. Your lab wasted a little bit of money on.
Basically, from a clinical point of view, everyone
was correct. Yeah. Okay. This is a high power to show that these things are discontinuous, different thicknesses. Okay. For some reason, we keep getting these things up. Okay. And this is, by the way, ish to show you there is no amplification. Okay. So we think is score 1+. Case 2.
Okay.
Here you are. We can do a poll.
Maybe you should have given a few seconds.
No, I think it's here. Good. 25, 30. Very good. Okay, we can end the poll and share results. So as you can see, most people thought this was ultra low, and a few people thought it was 1+. But okay, stop sharing. We'll close it. So Ade, what do you think of this diagnosis?
Yeah, so again, low power, I don't know, that might be in situ where I see a little bit of membrane staining.
Situ, yes.
And then I start to see a little bit, a few clusters at 10
maybe
magnification.
But not really. I can't see membrane staining here. But you can see it here at ×20.
Yeah, it's kind of weak to moderate.
Yeah.
But I think it's in quite, so this is 20 on the lower left. So I think this is more like moderate, but then we see quite a bit of weak. So I'm wondering, I'm starting to wonder if discontinuous, with a little bit of cytoplasmic perhaps as well.
Yeah, and you can see perhaps a little bit better ×40. ×40 is to show you that actually there are a lot of cells
showing some staining.
With membrane staining.
So to me, the proportion is enough for, at least in this area, for like a 1+.
Of course, so this is a silly exercise because it's based on pictures. You cannot study the whole slide, but providing this is representative of the whole slide, you would call it 1+. Yeah.
Yeah, it is.
So here the important message is don't call it ultra low just because it's so weak.
Yeah.
Is the percentage is important. Yeah.
Make sure that you've seen.
Fantastic. This is a higher power to show. It is really membrane staining. Okay. Yeah. So we think it's 1+. Case 3.
We should give a few seconds.
Few seconds. Why?
For people to see, because then
you see,
the poll comes up.
Yeah, but you see, I think Ade, these diagnoses are instant diagnoses.
I said a few seconds, not.
Yeah.
It's 1+.
Okay, so yeah, let's keep a few more people voting. Okay. So shall I stop and poll? Okay,
If you
share
like to.
results. So these are the results. So most people thought this was ultra low. Some people thought it was null, no staining whatsoever, and some people 1+. I have to tell you that I didn't say, but oops, comes up again. I have to say that one word of warning. I think we are doing this on a webinar with computers. It's not quite the same as microscope. And also, if your computer is very good and your screen is very good, you may see some membrane staining. And if it's not so sensitive, you will not see. So don't be too upset if you cannot see membrane staining. But actually, there is
especially in a case like this.
Yes, but there is a tiny little bit of membrane staining. I mean, obviously, nothing here.
Yeah,
nothing
at most
end.
it looks more like cytoplasmic and low power, but
So, but can you see at times 20 here? There is the occasional line. I'm not so sure. This is where actually, let's put times 40. And you may or may not be convinced that this is membrane staining. If you are convinced this is membrane staining, this would be probably ultra low.
Yeah, who knows?
Because maybe it's less than 10%. We don't know. We are hovering, it depends on quantities now. But if you don't think this is membrane staining, this becomes null.
Maybe it's between these two cells.
Shall we see what we diagnosed originally on this case? I think this probably is membrane staining. We think is in between.
Okay.
It depends on how many cells you can count on these things. Somebody is signaling that we are running out of time. No, we have 7 minutes. Cool, plenty of time.
Can I just drop in here to say that we have the other session starting at 4 o'clock on a different link.
So would you like us to do the last case and then we log out and log in?
So yes, I think because we need to allow a few minutes
guys.
for the session.
Sorry. Okay, but this is an easy case. Let me find another one. This is a nice case. I don't know if it's a nice case. Okay, what do you guys think of that? Let's see what you think of that.
A different case.
Okay, but this is really good because everybody has logged into the fact that this is either 3+ or 2+. You know, there is very little hesitation on this. We can share results. Share results. Okay, so mostly 2+, but some of you thought it was 3+, a minority, and then one. Okay, this is a high power, but Jesus, we need to get rid of this. But let's see if I have an ish. Yes, actually. So here is the ish. So those of you that were tempted to say, "Oh, look, I can see membrane staining at times 5,"
which is correct.
But is it circumferential? Ask yourself. Is it really circumferential? Can you really identify 10% of the cells unequivocally that you can see without bursting your eyes with circumferential staining? Or would you think, actually, let's play safe, let's do an ish, let's call it 2+. And you can see here, in fact, when you go a high power, there is thin and thick. Thin and thick are often not associated with amplification, so be careful. And this is the issue. There is no amplification here. Okay, Sarah, do you think, I think we have 5 minutes. We can stop here. We may have 1 or 2 questions if anybody wants to ask questions. I'll stop sharing. And then
I think some of the questions have been answered on the chat, actually, with Simona has chipped in. So
Simona, well done. Thank you.
Thank you.
Bless you.
So I think probably we should finish this one here. And I think Hannah's put the link for the next session for those who want to do the DDish session on the chat. So
exciting. DDish.
I think they'll be back in a few minutes.
Okay.
But thank you very much.
Thank you. We'll see you soon. Bye.